is Ahmed Al-Awamir, and his seminar is entitled, How Did Medical Assistance in Dying Impact Palliative Care? Before I introduce today's speaker, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Center for Bioethics website. The format of our seminar today is a presentation by our speaker, followed by a facilitated discussion period. We would like to take a moment to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. We also stand in solidarity with the ongoing protests against racism and systemic discrimination. Now, it is my pleasure to introduce you to today's speaker. Dr. Al-Awamir is an assistant professor in the Department of Family and Community Medicine at the University of Toronto. He is a staff palliative care physician and an educator at the Supportive Care Department, Princess Margaret Cancer Center in Toronto, Canada. Dr. Al-Awamir is a native Saudi Arabian and obtained his medical degree at King Faisal University. He completed residency training in family medicine and palliative medicine at the University of Toronto. After completing his medical training, Dr. Al-Awamir obtained a Master's of Health Sciences degree in bioethics at the University of Toronto. In his various roles, Dr. Al-Awamir is currently the Palliative Medicine Clinical Fellowship Program Co-Director and leads education at the Princess Margaret Cancer Center, Canada's largest academic cancer center. Also, he is the head of the curriculum committee at the University of Toronto's Palliative Medicine Residency Program and DFCM Palliative Care Enhanced Skills Program at YAC. Dr. Al-Awamir research interests include advancing palliative care globally, models to provide palliative care for adolescents and young adults, medical education and curriculum development, and end-of-life ethics. He has published and delivered conference papers nationally and internationally about palliative care and ethics. Dr. Al-Awamir, welcome, and over to you.
Thank you so much, Angel. Good afternoon, everyone. Thank you so much for joining us today. I will talk to you about the impact of MAiD on palliative care. Considering our situation and the COVID outbreak, we thought that we give you some break from talking about COVID-19 and all the things that are happening right now, and talk about something else today. So I hope I hope that we can engage you in today's discussion, and I'm very thankful for taking the time to join me. So to begin with, I don't have a conflict of interest apart from my own personal views about MAiD and about palliative care. I know that some of you are quite expert in medical assistance in dying in Canada, but for the people who are joining us and who may not have a lot of information about MAiD in Canada, I'm just going to give a brief introduction. So MAiD, or medical assistance in dying, is a term that encompasses all actions that are meant to cause death for patient, whether euthanasia or assisted suicide or any other term. It became legal in Canada in June 2016. It is available for 18 years old and older with a grievous and irremediable medical condition. Now, MAiD, usually it follows certain process, and usually for a person to request MAiD, they need to submit a written and witnessed request. After the request, the process includes having 2 independent assessment by either a physician or nurse practitioner to determine the person eligibility for MAiD. After the person deemed eligible, they usually notified in written, and there is a 10 days reflection period that start from the day of the notification or assessment until during this time, the requesting person are given the opportunity to think about what they want. After the 10 days period, they can proceed with the request. Now, advanced medical directives and substitute decision-making are not allowed, meaning that only the person can make the decision about MAiD. So if the person is incapable or cannot consent, that means that they cannot go for MAiD. So this is one of these decisions where substitute decision maker cannot make decision on the person's behalf. What about palliative care? So palliative care, I find, means different things to different people. So we're going to stick to the international definition of palliative care, which is the measures that aims to improve the quality of life of person with life-limiting illness and their family. And it tackles physical, psychological, and spiritual areas. Now, palliative care internationally has been recognized as a human right under the right for access to medical treatment. Now, in Canada, despite being one of the pioneering countries for palliative care, one of the first few hospital-based palliative care programs were actually started in Canada, we're still having issues with the access. Like the latest framework for palliative care in Canada showed that only 15% have access to specialized palliative care at home. Now, since the introduction of MAiD, palliative care is separated from MAiD. So there are two different services. There is no overlap. However, during the debate about legalization of MAiD, palliative care was central to this discussion between people who felt that MAiD should not be approved, and palliative care is the alternative for MAiD, and between other people who felt that palliative care is not giving enough choices to the patient. So since before the debate, palliative care and MAiD, both of them, they were part of the debate of legalization, of MAiD legalization. Now, let's take a minute here to look at the status of MAiD in Canada. So far, we have 5,631 cases, up to 2% of all deaths in Canada is MAiD. Cancer is the most common cause. One of the main challenges, cancer is the most common underlying problem for people who decided to go for MAiD. One of the challenges that we have is there is a knowledge gap about the challenges and opportunities for palliative care providers that was created by MAiD. The research also is not very informing when it comes to the impact of MAiD on palliative care. And this is this takes me to the discussion today. So what we end up doing, we conducted this study that looked into what is the impact of introduction of MAiD on palliative care. We try to dissect the experience of the frontline palliative care provider and look into their experience, what they have noticed different now that we have MAiD available, and what opportunity or what challenges the introduction of MAiD has created for them. Now, in doing this study, we recruited palliative care nurses and physicians. We mainly choose to focus on palliative care nurses and physicians because of their direct involvement in MAiD, whether in obtaining information or providing support. Although there are other valuable members of in the palliative care team, like social worker, therapist, occupational therapy, and all of that, but most of the time they're not directly involved with MAiD, and this is why we decided to focus on them. But I think the there is a need also to explore the other team members of the palliative care group. We invited people who practiced at least 6 months before the introduction of MAiD. So they have the ability to reflect on their prior experience and inform the study team about the changes they witnessed. We used purposeful sampling, so we kind of invited people whom we think might have interesting views. We try to be as diversified as possible. MAiD is very a contentious topic, and we wanted to make sure that we invite people who are conscientious objectors and people who are supportive, and we wanted to make sure that we include people with all views on MAiD. And this is why the purposeful sampling was extremely helpful. We did interview using the guide. We were able to invite 23 participants from Southern Ontario. Now, in terms of the scope of the practice, some of the participants were actually working in hospitals and providing palliative care as part of their hospital. The other type of the providers were people who works in the community, so mainly home-based, and the rest of the group were actually working in palliative care unit and hospices. So again, we wanted to make sure that all settings are covered and captured. In terms of the involvement in MAiD, we have, this is the level of involvement. So you see in the study, we have people who discussed MAiD with their patient, palliative care provider who made referrals, and there are MAiD there are providers, palliative care physician or providers who completed assessment. Some of them witnessed MAiD procedure, and there are also 3 providers. In terms of the results of the study, so the study showed 6 main themes that came up from our discussion with the participant. And I'm going to talk about each of the themes alone, starting with the alternative experience to natural death. So all the participants spoke about the fact that they felt that the dying experience with MAiD, it's different from natural death. There is definitely a difference. Now, what does this difference mean? A lot of times we find that the participants use their own experiences, values, belief system in order to interpret the new dying experience. So for example, some of the people who supported MAiD, they felt it's actually a very positive experience. A palliative care physician who provided MAiD said, the families are so pleased with how things went. In contrast, often to natural death is, to be honest, lots of time natural death are grim and lots of unpleasant symptoms. Even though we're trying everything, maybe that's what scares me about that MAiD is so positive. On the other hand, for example, another physician spoke about the relational strain and how the dying experience actually created a lot of conflict, and there was some strain that it was not a positive experience as they hoped it to be. So another physician who's a conscientious objector said, I'm really so invested in making dying experience a warm and supportive things. MAiD just felt like the opposite of that. This is sort of cold, isolated way to leave the world, and I found that sad. Moving to the next theme, which is the challenges that was created to symptom control. So a lot of times, the palliative care team, in terms of managing the symptoms, they use medication that may have some sedative effect to help manage the pain and manage the symptoms. However, these medication might sometimes result in sedation, and it may affect the person eligibility for MAiD. And that has created a lot of struggle for the physicians or for the practitioner in general, because they were unable to use their medication as they used to be. And there was also worries about really providing comfort treatment for palliative care patients. There is a quote from one of the physicians who said, I worry about inadvertently affecting their ability to access MAiD. There is a reluctance toward using benzodiazepines, or opioids because of the fear they'll get sedated. And sometimes from them means the patient, but sometimes it's from me. And by the way, this is very common theme that a lot of people talked about it in the interviews. Moving to the next theme, which is a big one. It's about the new difficult conversation that was created by the introduction of MAiD. So the practitioner talked about, or the participant talked about, how having now MAiD as a legal and available option has created actually new communication challenges in palliative practice. So for example, one of the new challenges, the new difficult discussion is determining the time of MAiD. So for example, P7, who's a physician, talks about there is a lot of uncertainty about the patient prognosis and the evolution of her disease. And she's not sure when to set the date for MAiD, nor can I give her clear guidance on that either. All we know that one day things will change. And this speaks about the challenge that patients go through when determining the timing of their MAiD, and how a lot of times they ask the guidance of their physicians or their team, not physicians only, and this could turn into a very difficult conversation. Now, this conversation did not exist before MAiD legalization, because at that time there was no timing to determine. Another challenge that was identified under the same category is the ethical and moral dilemmas that was experienced by the participant. So for example, one of the nurses spoke about her struggle with the appropriateness of certain discussion, like for example, introducing MAiD. So the nurse said, I wonder if I should speak to ethics about bringing up MAiD with patient, because maybe they can tell me, no, you're allowed to say this, or no, you're not allowed, or no, you're not allowed to say that. But I feel I'm walking a quite tightrope, because I don't want to be encouraging or discouraging in any way. I'm sorry, I'm just having some technical challenges, and this is why I'm slow in reading some of these codes. But again, to go back to the discussion, this is like one of the issues. So as the MAiD introduced, there was a lot of unanswered question as we learn. And this nurse talks about her challenge. Like, there is a lot of things. I'm not sure, should I do it? Should I not do it? And this is one example. Another challenge that was created is the conversation and the support around MAiD. So one of the nurses spoke about how is it challenging a lot of times for patients and for their families to come to decision of MAiD and to bring everyone on the same table. So I'm going to read the quote here. They, patient considering MAiD, struggle. Many patients say, I love my kids How can I choose to leave them? You know, those are big words, and it's hard to know how to respond to some of them. And again, the participant also spoke about sometimes the conflict that happens between family, like family may not be very uh, uh, supportive of the MAiD decision. And a lot of times they reach out to the team, and patients also worry about they upsetting their loved one. So a lot of times there is a lot of different dynamics that happens during making these decisions. And most of the time they reach out to the palliative care team to help with sorting out some of these conflict, or they reach out also to the team for support. Although the palliative care team is not the MAiD team, but still like they provided all the indirect support for MAiD, which is something that was not really existent before the MAiD legalization. Moving to the next theme, which also talks about the toll that MAiD had on the palliative care provider, whether emotionally or personally. So, so some of the participants spoke about how the MAiD experience was different and how it created some emotional toll, especially in the first exposure. One of the nurses spoke about her experience with first MAiD case. So she said, I was prepared as I could for our first MAiD case, but I recall that morning I went outside and I felt like I was about to throw up. And this is a common experience that we hear from the participant, the shock that happens, especially with the first few cases. Another nurse also talked about the fear of social stigma around their involvement. They are not directly involved in MAiD, but the fact that MAiD is provided in their institution, it was also, it created some fears. So this nurse said, what would my family think I'm working on a unit that does MAiD? Do I hide do I hide it from them? What if people find out that we do that? Are people going to come up here and start protesting? People will see that as evil. Now, it's not all negative, what we heard from the participants. Some of the participants find actually the experience to be positive. So, for example, one of the MAiD providers spoke about the sense of personal and professional satisfaction for supporting the patient wishes. The physician said, I'm not going to tell you, I look forward to them, meaning providing MAiD, but when they happen, I actually find them such a beautiful experiences with family. It is the shared experience with family that you are with that, you have the opportunity to help. Now, one of the conscientious objectors, physicians, spoke about their experience and how things changed over the past 3 months from their perspective. So over the time, there was the initial shock, but over the time, there was some sense of tolerance among the palliative care providers. So this doctor said, initially, there was very strong opposition from palliative care providers to MAiD. Just the very idea that MAiD would be considered an end-of-life option. Now, the same physicians who were strongly opposed are understanding. They see a parallel system that exists for MAiD, so they palliative care could exist with that. And that was a very actually important reflection in the study. The second, or the next theme is about the impact that MAiD had on the patient palliative care provider relationship. So, for example, one of the physician spoke about how sometimes providing MAiD as part of the palliative care team created some confusion. So this is a participant who work in an area where MAiD is provided by the palliative care team, unlike what's the system that is set up in most of the institution. This system was unique in that the palliative care providers, they provide MAiD. And the quote is, there was one family was very concerned that we were also the MAiD team. They had a huge fear that that was the palliative care, and that we were somehow going to do something to facilitate this death. Another provider spoke about some of the challenges of conscientious objectors and how MAiD has actually created some challenges in terms of patient relationships. So this conscientious objector said, I told her as soon as the topic MAiD came up that I was conscientious objector, and the person said, you are not on my side. Even though she was getting the service MAiD, I was seen as somebody who was not helping her. So again, this is a conscientious objector physician who was reflecting on how sometimes this can create a challenge for them. Despite that the physician was actually very committed to their patient and they wanted to provide care and they continued the support, still they were seen as outsider, which affected the relationship. The last theme that I have is, the last theme that I have is about the impact on palliative care resources. So, and this is something that was actually strongly showed during the interviews. Because there was a lot of indirect support for MAiD that is needed and provided by the palliative care team, it felt like it consumed a lot of palliative care resources, which is scarce to begin with. So one of the participants said, good palliative care takes a lot of time and interdisciplinary resources. When a patient requesting MAiD, most of the resources have been sucked up by that one case. And it's all everyone's talking about, and they are rushing to get stuff done. Everyone from admin down to the bedside nurse is focusing on MAiD. And all of the high quality palliative care that we do falls by the wayside for other patients. Another quote that also helps us understand some of the strain on the palliative care resources is an example that provided by one of the nurses about the practical preparation for MAiD intervention and how that indirectly consumed the nursing resources. The last MAiD intervention, it was in the morning, and it was a struggle around getting this individual prepared for MAiD, a bath, a shower, whatever he needed, dressed in terms of his dignity, then doing the rest of the care. We palliative care nurses need to be thinking about what the timeline of it is for the team. We need to bring in a second nurse to be present, to be there before and after the family. There is certainly practical stuff to providing MAiD. That is like 2 palliative care staff, and then the family wanted breakfast. So there were like 10 people, family and friends here. And the palliative care volunteer provided breakfast for everyone. There is a sense of ceremony before MAiD. So those all have impacted in terms of, have impacts in terms of resources. Another example of how MAiD requests have actually created a challenge for the resources is the fact that most of the MAiD request has been left to the palliative care teams to deal with. So for example, one of the physicians spoke about that. Yeah, they don't really want to be engaged in the MAiD process at all. They want us to do that. I think we are taking on more of this because other people want. Let the palliative care deal with that. It's important to mention here that according to the policies and the laws, any physician should be able to discuss MAiD request with their patient. And it's not usually palliative care team that should be doing that. However, in the reality, most of the people wanted to delegate this task to palliative care, which actually created more strain on the resources. So these are the themes. In terms of the analysis, if you look at all the themes, you realize that based on the frontline experience, after the introduction of MAiD, there was some profound impact on the palliative care providers and in their practice. MAiD was actually very helpful in terms of heightening the public awareness about the importance of palliative care and the importance of having quality end-of-life care. However, the introduction of MAiD created some challenges, and a few of the things that can be done in order to help is actually enhancing the teaching of communication. A lot of times we find that the focus of the communication is on actually responding to MAiD requests, but there hasn't been really emphasis on the conversation around MAiD. Things like that, what I talked about, like supporting families, like supporting patient, responding to certain questions, responding to ethical dilemmas and ethical questions. So all of these things can be done better. The other thing that also we learned from the study is the importance of having ethics resources, specialized consultation and support for ethical decision making. I think the participants spoke about some of the challenges and the struggle they have. And having this having this support from ethics, we feel is extremely important. Another important point to take into consideration is the importance of educating the general public about the role of palliative care and it's about its benefit, and hoping that this education will help reduce the stigma around palliative care, because you can see from some of the examples is that the confusion that the confusion between MAiD and palliative care and how this impacted some of the care for the patient. There is also some participants spoke about the fact that some of the MAiD patients did not really want to engage with palliative care team because they just wanted to get MAiD and get done with it. So having this understanding and public awareness about the importance of palliative care, we think it's extremely important to improve the quality of people with life-limiting illness. The second thing, the other thing that we find is also important is we need to have more studies to understand the moral distress around MAiD and how can we support the palliative care providers. A lot of the participants spoke about their experiences and some of the challenges and the struggle they experienced and they face, whether in terms of their relationship with patients or in terms of struggling with some of the decisions. So there is need to understand the moral distress and see how can we support the participant. Although we talked about the distinction between MAiD and palliative care, we still feel like a lot of the indirect support for MAiD was provided by palliative care. And this is why there is a need to understand their struggle and how can we support them better. the other important point is is for policy makers and leaders is to understand that the impact of MAiD on the palliative care resources. I think when MAiD introduced, there was a lot of emphasis on MAiD process itself, like, for example, making a MAiD assessment available, making MAiD intervention available. And they've done actually a very good job in doing that. But there wasn't really a lot of discussion or any attention to the details of supporting MAiD patient throughout this process. And this was mainly left to the mostly to the palliative care team to deal with, which actually created a lot of strain on the resources. So there is a need to be mindful of the importance of that and its impact also on the workforce and on the manpower. Another thing that I wanted to mention is when it comes to also supporting the palliative care team is having to understand also the perspective of people with conscientious objection. Again, a lot of these providers, they want to do the best for their patient and they want to remain involved and engaged. But sometimes it can create more stress and it may be helpful to understand how can we support them as well. One of the observations we noticed during our study is that there was a lot of people that we approached who did not really want to talk about their experiences because they felt they were they have their own personal views about MAiD and they, because they could be seen as conscientious objectors, they did not feel very safe to share their opinions or their thought, or they felt that they will be judged. And this observation may be also impacted by the fact that we only invited participants who worked in institutions that provide MAiD. So some of these providers, they felt like these opinions will not be welcomed by their institution. And this is why we had difficulty recruiting some people with known views about MAiD. In conclusion, healthcare leaders and palliative care providers should be aware of the impact of MAiD on palliative care, and healthcare system should be equipped with the necessary support to ensure that palliative care can be delivered effectively and universally along the provision of MAiD. There is need for more resources, and there is also need for education and support and ethical consultation and ethical support in order to help the people in this area. If you are interested in reading more about what we discussed today, you're most welcome to read the paper, which is published in the Palliative Medicine Journal. Thank you so much for your attention, and I'm happy to take any questions.
That was great. Thank you so much, Ahmed. So we're going to go to our discussion period right now. For those of you in the audience who would like to ask a question, you can do so via the YouTube chat. And if you're not logged into YouTube or want to send a question anonymously, you can email Lori Balchuk at utoronto.ca. So I see there's been lots of discussion and comments and questions in the chat box. And what I'll do, Ahmed, is I'm going to read I'll start with the questions, and then we'll turn to the comments in case there's anything you want to say in response to the comments. So our first question is from Carl Ulrich. He asks, what positive things can be done to help us reach a point where palliative care and MAiD can work together with people able to choose whatever works best for them?
I think both services exist right now. So I think what we need right now, as I mentioned in the comment, is that there is need to pay attention to the challenges that MAiD have created for the palliative care providers, and continue to work with these providers to provide the needed support, whether in terms of resources, in terms of education, about ethics, about communication, or in terms of also support for the moral distress that may be created. I think right now the system include both, and I think they're both available, but we just need to be mindful of some of the interaction between the two, and we need to continue supporting continue support each other.
Thank you. Our next question is from Jaron Wang, and I know somebody has answered in the YouTube comments as well, but if there's anything you'd like to add. Jaron asks, if the person has issued a will to have MAiD performed, but they aren't capable to consent at the time of the disease is presented. So for example, if they have a brain injury, does it count as a type of valid consent? And in the comments, people have said, no, you need to be capable. But I'm wondering if there's anything you'd like to add to that.
So I'm not a MAiD expert. So if you have questions about MAiD, I may not be able to answer them with authority just because I'm not expert in that area. My expertise is mainly in the palliative care. So there might be people who are more experienced in this, but my understanding is that the person has to be competent and able to respond at the time of the assessment and at the time of the intervention. If they're unable to respond, even if they have advanced directives or power of attorney, it does not work. They're not eligible.
That's right. So I can confirm that right now, the person receiving MAiD has to be capable at a few points in time, including right before the procedure happens. But in response to Jaron, there's a change in legislation that is upcoming and to be determined sort of what is approved in the next month. So keep your eyes open. I think mid to late February, we'll have some more answers to what the new legislation will look like. All right, our next question, scrolling through the comments here. Christy Sororta asks, can you please talk a bit about researcher reflexivity? What are your beliefs on MAiD and palliative care, and how you think this position influences your qualitative research on the topic?
That's an excellent question. We talked about this a lot because topic is such a contentious topic. And people have different opinions about that. We wanted to make sure that we remain objective as much as we can, which is still difficult when we're doing qualitative research. So I personally have public view. I'm a conscientious objector because of my religious view. However, in this study, we wanted to make sure that we are inclusive. The rest of the co-authors have different views about MAiD and about palliative care. So we wanted to make sure that we have diversity of views within the co-author. Before we started the discussion, the data interpretation, we made sure that we disclose all our biases about our views, and we just try to work with that. But that's an excellent question.
Thank you. Our next question is from Sylvie LeMay. They ask, regarding consuming resources, do any palliative care providers in your survey think that once someone has requested MAiD, that they are no longer palliative care patients?
I'm not aware of anything like that. I'm not aware of that. again, whether we're able, like what usually happens is that because the way the system exists, most of the time there is a MAiD team and there is a palliative care team. In most of the institutions, there are exceptions, but being like requesting MAiD or eligible for MAiD, I'm not aware of any time where the patient told that, no, you're not eligible for palliative care because of your MAiD, at least not in my institution or the people that I talk to. We all believe that palliative care should be available and provided for all patients, irrespective of their wishes, whether to go with MAiD or not, explore it or not. Palliative care is still like central part of the care and should not be taken away.
Okay, thank you. So Tim Mount Pleasant asked the following. It is important to see where MAiD fits within the standard of healthcare services. Is MAiD part of palliative care? Is it a part of all healthcare services? Perhaps MAiD is not an intersection of palliative care specifically, but at the intersection of all services in which MAiD is appropriate. What are your thoughts on that?
I think the way it is presented, that MAiD is part of all services. However, in the reality, as I mentioned in the study, most of the people, they kind of leave it to the palliative care to deal with, which is this is the one of the big challenges. This is one thing. The other thing is a lot of times people who request MAiD, they are in palliative care institutions. Mm-hmm. So a lot of times there is this ongoing support that happens for patient, but because of the stage of their life, they are, for example, admitted in palliative care unit, or they are cared for by home visiting palliative care team. So because of that, everybody felt it's for the palliative care team to deal with. I think from a system perspective, it should be anyone. It should not be just limited to palliative care.
Thank you. Melissa DeBauer asks, is it appropriate for palliative care to support cognition, for example, with steroids, in order to achieve MAiD?
Is it appropriate for palliative care? So I don't know if you're talking about symptom management or you're talking from an ethical perspective. From symptom management, we do everything we can to optimize the quality of life of our patient. That could be improving their energy, improving their alertness, anything that we can do to help, irrespective of the MAiD decision. This is something that we usually work with our patient. So, so if using steroids is something that's going to help our patient remain awake and do the things that they want to do and they enjoy, then we will work with our patient to do with that.
Thank you. And we have an anonymous question. They ask, MAiD is a very time-limited intervention. Please explain how MAiD takes away significant resources and personnel from the provision of palliative care.
So I think in the study I mentioned, like we talked about that. We talked about examples of the conversation that MAiD create, whether with regard to proceeding to MAiD or not, which is something that usually palliative care teams are asked to help with. Although we're not the MAiD team, but a lot of times there is a question, there is a lot of support. We talked about the relational strain that could happen among the family at the time we're considering MAiD, and how a lot of time this is left for palliative care providers to support. We talked about how I gave also the practical example that one of the nurses mentioned about how planning for the intervention itself, because the team wanted to be very patient-centered and they wanted to help their patient. That comes with certain requests of how MAiD should be planned. And these requests took, in doing this, in fulfilling the patient wishes, it created more demands for the palliative care providers. And I can reflect on my experience as a practitioner. I remember that I spent countless hours in supporting patients who felt like they wanted to go for MAiD, but they didn't know when to go for that. And there was a lot of internal struggle, and they felt like I am the only person whom they can talk to about their worries, about their fears. So again, this is not directly MAiD, but there is this indirect support that I had uh, to stay there and provide the support for my patient. Okay.
Sylvie LeMay says that the MAiD nomenclature uses the word provision, and they ask, does the brain injury case allow for discussion into terminal sedation? So I think maybe they're asking for the relationship between discussions around MAiD provision and other options. Perhaps also if someone is making a future wish, Sylvie might be talking about the example that was given earlier with an advanced wish related to the brain injury case.
Yeah, does brain injury case allows discussion into terminal sedation?
Sylvie, if I've misunderstood, if you want to just clarify in the comments, we can pass that along.
I think they were asking if I understood correctly, if someone has brain injury, would they be eligible for terminal sedation? Or would their family be able to consent on their behalf to have palliative sedation? If this is the question, then yes. And I think there is a lot of confusion between palliative sedation and MAiD. And this is one of the challenges that MAiD. Sometimes palliative sedation is presented as an alternative to MAiD. If you don't want MAiD, then we can do palliative sedation. And this is not correct, because palliative sedation is a different procedure. It's mainly there to be used for refractory suffering. So there is certain criteria, there is certain process, there are guidelines. It's not supposed to be used as an alternative to MAiD. It should be used in the appropriate patient who have refractory suffering. And there is a certain steps for that. And with regard to the question about the consent, the family can consent, or the substitute, sorry, not the family, the power of attorney or the substitute decision maker can consent on the person's behalf to receive continuous and deep sedation.
Thank you. So we have an anonymous question. They ask, when will we begin to speak of end of life rather than to continue this polarization of palliative care versus MAiD? I was concerned that most of the quotes were focusing on the problems of MAiD taking resources from palliative care and moral ethical dilemmas of palliative staff. This did not seem a balanced presentation of the pros and cons. Also, if a person dies with MAiD, in fact, they reduce the amount of time and resources that would be needed to had the person remained in palliative care.
Yeah. Well, thank you for the comment. MAiD is very contentious topic. So we had the same exact experience when we're interviewing people, when we're trying to interpret and review data. There is always someone on the other side who's feel that we're biased toward the others. And again, I don't think we operate in total volume or in vacuum, sorry. So there is a lot of influences. The goal of the presentation and the goal of the study is to help people understand some of the challenges and how to improve them. The goal of the study is not to finger point at palliative care or MAiD. The goal is really to understand what are the experiences of people at the front line, and how can we support these experiences. The resources example that we brought, it's a life-lived experience that was reported by the frontline experience, and it's something that came up in all the discussion and all the themes. And I feel like we need to pay attention to that, because a lot of times when people talk about it, they think about the access, but they don't think about all the other indirect support. So hopefully by having more understanding, we can actually be more holistic and we can provide support for both.
Thank you. So I see we've got a few more minutes and we have 2 more questions. I'm hoping we can get through to those. And then there are lots of comments. So what we'll do is we'll pass those along to you and invite people to continue the conversation offline or via email. That would be great. So our next question is from Michael Rackless. They ask, did healthcare providers ever feel that their patients were requesting MAiD because they felt they were a care or financial burden to their families? Is that something that came up?
It did not came up during the discussion.
Okay. Jay Henderson asks, have you dealt with cases where the patient wants MAiD and the patient won't allow family to know? So issues around patient confidentiality.
It happens a lot, and it can be very challenging. So there was many cases where patient wanted to pursue MAiD, and they did not want their family to be aware, and it can happen. It creates significant challenge. We always encourage our patient to have open communication with their loved one. But if they don't want to share it, we cannot totally respect that. But you can see sometimes the tension that this could create. I remember many cases where this is the case, and it was actually stressful even for the patient themselves, because they were worried that their wishes will not be respected by the family, and this is why they choose not to share it with them. So it kind of create this isolation.
And we have time for one last question. This question is from Mary Bishop. They ask, was there any consistency in the comments based on the sex of the participants? So I guess sex or gender differences, if those were noticed by the research team.
Yeah, so if you look at the study, you will find that most of the participants were female. This is the nature of the of our practice for the time being. So so I'm not surprised. It just because this is the way the practice being set up, and the study was representative of actually the current workforce. So yeah, so most of most of the people who were commenting were female.
Thank you. So we are going to send all of the comments and any questions that have come in that didn't get answered. We'll send those all your way. And it's time to draw today's seminar to a close. So I just have a few announcements to make before we thank our speaker. Our next seminar will be on Wednesday, January 20th. Dolly Menadak, Aman Siam, and Kara Sodoma will be discussing balancing family presence in a pediatric hospital during the COVID-19 pandemic. To sign up to receive our weekly seminar reminder emails, please email jcb.info@utoronto.ca. For the CSB students enrolled in the CSB Student Seminar course, please remember to keep track of your attendance. And for those of you who would like to share any additional questions or comments with Dr. Elwamer, please contact Lori Bulchak, and I think her email is there in the YouTube channel, and you can she'll be sure to pass along any feedback. And finally, Ahmed, on behalf of all of us, thank you very much for your presentation today.
Thank you.
Thanks.